Hi everyone, this is Dr. V. Sivaramakrishnan. I welcome you all for this presentation on stem cell treatment for diabetes. Diabetes is a non-communicable lifestyle-based disorder that is characterized by excessive levels of blood sugar. In the clinical terms, we call it as hyperglycemia. As per the global incidence, currently 137 million patients worldwide are diagnosed for the occurrence of diabetes. And if you can segregate the types of diabetes as actually type 1, we have type 2, and there is also the third kind which is less predominant, which is happening only in pregnant women, particularly in the first trimester of their pregnancy. It is called as gestational diabetes, probably even in the third trimester also, to correct myself. Yeah, and if you look at as per the global epidemic incidence that is reported by World Health Organization or WHO, they state that up to 30 million people in the worldwide, approximately in the developed world alone, are probably affected because of diabetes. And the treatment that are basically available, or the drugs that are available in the market, basically the global market, states that for the diabetes management, it's of the value of $114 billion as of 2018, and this shall only increase further. Before understanding about diabetes, it is imperative to understand about the role of pancreas, the organ which secretes the exocrine hormones for regulating the blood glucose levels. And this would give you an information about how the hormones basically regulate the blood sugar levels. Pancreas is a gland which is located below the liver, next to the abdomen, which is adjacent to the duodenum. Okay, particularly where this particular cone-shaped organ is basically located. If you take the cross section of the pancreas, you can say that it shows the islets of Langerhans cells, which is actually said to be made up of, for particularly the four different type of cells, the alpha cells, beta cells, gamma, and as well as the epsilon. So out of the four type of cells, we have the alpha cells, which basically secrete the hormone glucagon, and the beta cells are the ones which secrete the hormone insulin, and the gamma cells which secrete actually the hormone which is called a somatostatin, which is the growth responsible hormone, and the epsilon cells which actually secrete the hormone called as ghrelin, which is responsible for controlling the hunger. As you can observe, out of the four different type of cells, the most important one happens to be the beta cells, pertaining to understanding about the diabetes management. Beta cells, as I said already, they represent secretion of an hormone which is called as insulin. This particular hormone is responsible, or it facilitates actually the uptake of glucose by different cells present in the body. Particularly, it could be even a liver cell, fat cell, or a muscle cell, so on and so forth. So that, as you know, glucose happens to be the main fuel source to most of the cells in the tissue, and that is particularly regulated by the insulin levels. As shown over here in this image, the beta cell is the one which synthesizes the insulin, and it is actually let into the bloodstream, where they are actually moving via the bloodstream, and then they are taken up by a particular cell at a particular tissue. Either it could be a liver cell or a fat cell, or maybe even a muscle cell. So in all these places, the uptake of glucose actually happens, where the insulin binding to the corresponding receptors, the insulin receptors which are present on these cells, are mainly the factors which play a critical role in actually the cell's ability to uptake of insulin. In continuation to the physiology, it is also important for us to actually understand about the biochemistry behind the hormone, or the peptide hormone, which is called as insulin. Insulin, as you know, is made up of two chains, which is called as the alpha chains and the beta chains, and they need to be packaged and cargoed within a cell before they are actually moved to the exterior component, which is the blood vessel. So what is actually happening here? This process is actually called as cellular trafficking. How insulin is actually cargoed. So this process begins particularly at the Golgi cisternae, or the cis component of the Golgi network, where actually more and more insulin is said to be accumulated, and they form an aggregates, and these aggregates are slowly moved to the trans-Golgi network, and from there in clathrin coated pits the initial immature secretory vesicles are basically formed, and then they are actually converted to generate the final mature secretory vesicles which contain the aggregates of insulin. After this four-step procedure of cargoing or cellular trafficking process, it involves a three-step procedure how the hormone is basically released into the rapidly into the bloodstream. The first case scenario is that the clathrin coated or the mature secretory vesicles are actually said to be integrated or docked into the cellular membrane, and once the docking process actually happens, this involves in actually fusion of the secretory vesicles to the plasma membrane and causes the release of the hormone which is called as insulin into the final stage, which is the release of the insulin into the bloodstream. The electron microscopic image of the release of insulin is shown here in this particular figure. Okay, with the already known information on a preview about the physiology and the biochemistry of insulin hormone, now let us look at the types of diabetes. Diabetes, as you know, can be categorized into three different types: type 1, type 2, and the gestational diabetes, which I already mentioned. Out of which we shall see the predominant ones, what is happening at a cellular level. In the case of type 1 diabetes, this is an early onset disease, and this is a scenario where it is considered to be as an autoimmune disorder. It's nothing but where the host T cells, they actually detect their own islets of Langerhans beta cells as foreign cells or antigens, and they start to destroy them. And as you know, these beta cells are basically present in the pancreas, and naturally when one's own T cells starts to attack them and then destroy them, invariably there are no beta cells available for the secretion of insulin. So this results in lack of insulin production in course of time, and these people generally have a higher amount of blood glucose levels or the clinical condition which arises, which we call it as hyperglycemia. So this is what is the scenario which is observed in type 1. What happens in type 2? Type 2, the scenario is any one of the possibility where there could be lack of insulin production, or there could be even a deficiency of insulin production. Okay, so in either case scenario, we shall see probably one of the scenarios where, like, first, though the insulin that is properly secreted in them, the insulin is still available, the beta cells produce the insulin, but what actually happens here is invariably the insulin cells, I mean to say, the insulin, when it is transported or when it is cargoed and then released into the bloodstream, when it is traveling to a particular tissue or a cell, basically it could be a fat cell, muscle cell, or liver cell, invariably on the surface of these cells we have the receptors for the insulin binding, and there could be a problem either with the insulin receptors or a mutation which is actually preventing the proper binding of insulin to its receptors, or there could be also a problem which is involving the transporter proteins which is called as GLUT2 or the 4, and this particular transporter proteins are very critical for actually opening and closing, and if there is a mutation, invariably what happens, though the insulin is bound to its receptor, the uptake of glucose from the bloodstream which is passing through these transporters can be actually hindered, or there could be a problem if there is a mutation happening in the particular transporter. So in either of these scenarios, this will result in actually the insulin properly that is actually produced by the pancreatic cells in these people, but they are actually resistant. The reason is that it is still ineffective in them, and this also could cause the occurrence of a hyperglycemia condition or an increase of blood glucose. So to broadly differentiate between the type 1 and the type 2 diabetes, type 1 represents the juvenile onset kind or the early onset kind, which is typically affects in the children and as well as young adults. In the case of type 2, it's an adult onset disease which is typically affecting elderly people who lead a very sedentary, and as well as among the people who have the obesity condition or the overweight individuals with a family history of diabetes. The case of type 1, as I already mentioned, here it is an autoimmune disorder where one's own beta cells are restricted by the T cells, and in the case of type 2, The body cannot use the insulin that is actually produced effectively. And in the case of type 1, glucose does not enter the cells and therefore it actually accumulates in the blood. And in the case of type 2, due to insulin resistance, glucose starts to actually accumulate in the blood. So this invariably leads to certain kind of clinical problems. And what are they? Generally we call them as the microvasculature or macrovasculature related problems. And if you consider the possible complications basically include actually the blindness occurring in people in course of time, and probably the problem of heart attacks, or people suffering from kidney failures, or invariably also in people who already have an existing injury present in the foot, or probably certain part of the hand region. Invariably if they leave it unattended for a longer duration, invariably in people who are having already diabetes, that would actually lead, the one way of treatment would be to amputate the leg or the arm if such injuries are left unattended. The existing treatment that is available for diabetes is not a permanent cure basically, but it's more of a palliative care, wherein the patient's glucose levels needs to be constantly monitored, and if required, insulin shots needs to be actually provided to these patients. Insulin injections, they do not actually prevent the cumulative damage actually because of the disease. It's only a kind of a palliative care as I suggested. Difficulty in balancing the diabetic patients medication is a problem if they have any other kind of other complications like blood pressure or heart related ailments present in these patients along with diabetes. So the drugs that they basically take for actually the treatment can also sometimes lead to, if not properly monitored, can also lead to the condition of both even hypoglycemia or maybe decrease in the blood glucose levels or a sugar level drop. Or they could also have a scenario where the drug is actually whatever they are taking is ineffective at a particular dosage, and this could also lead to the occurrence of hyperglycemia condition also. So in either case, in this situation, they have to be constantly monitored for their blood glucose levels for actually providing them an adequate treatment option. Persons in the case of type 2 diabetes, they actually must control their blood glucose levels. There are certain kind of treatment options that is provided by the doctors. What they suggest is to act, since it's a lifestyle based disorder, you can actually think about including the diet, which is actually much more nutritious, more fruit based diet, more vegetable based diet or more fiber based diet, and adequate amount of basic exercises needs to be followed in these patients and by these patients. And certain medications like the anti-hyperglycemic drugs invariably that is actually suggested to these patients, and if they are required, probably also daily insulin shots also needs to be taken by them. Now I shall introduce you to the concepts of stem cells, which is actually a cell replacement therapy, also called a cell replacement therapy for the management of diabetes. It can be broadly classified into three basic approaches. The first one is actually called as islet cell transplantation. It's just the beta cell transplantation. It could be performed by replacement of these beta cells from actually cadaver of organ donors. And what could be the downside for this particular approach is actually the shortage of the number of organ donors that are basically available. And the other problem is that in these individuals to whom you have to actually provide the insulin producing cells from another person, there is a possibility of immune rejection by the individual who is actually getting the transplantation done or getting the shot of the immune or the beta cells. So this kind of so to avoid this, basically these patients are provided with some immune suppressants, and a long term immune suppression is actually very important for actually providing the islet cells for transplantation in these individuals. The other approach is actually the stem cell therapy to regenerate islet function. and wherein the replacement of these beta cells or the insulin producing cells with the stem cell derived insulin producing cells. When I mean stem cell derived here, it could be actually called as like the pluripotent form of induced pluripotent stem cells, or we have something which is called as the mesenchymal stem cells or the hematopoietic stem cells. We can collect these type of stem cells from the same individual, take it and then do the differentiation in vitro in a lab or a cell culture lab, and then try to propagate the cells, and then further you can actually inject the cells back after the differentiation is performed to actually generate your insulin producing cells. You can inject it back into the same individual. So it is the same cells which have been isolated, or the stem cells which have been isolated from the same patient. So this could be very beneficial, and here the problem of immune rejection can basically be avoided. So such a stem cells that are isolated and differentiated in vitro can actually be transplanted in these individuals. So this is the second approach how you can actually replace the islet cells. And the third case scenario is the stem cell therapy to prevent the diabetes onset, wherein the modification of the host immune system by stem cell derived immune modulatory cells. What could be the sources of these islets of Langerhans beta cells, which where we can actually isolate from? We already very briefly saw in the earlier scenario where actually you can isolate it from the cadavers or from cadaver organ donors, basically, which is called as the adult beta cells for performing the allograft, and even from embryonic stem cells that are isolated from embryos. You can actually perform the differentiation of these cells further to generate the beta cells, and then do the transplantation by the allograft procedure, or from the same person itself by using the autograft procedures. You can actually, from the donors, you can from the same person you can get the beta cells and then use it for the transplantation process. Or in olden days they were actually doing it from the pancreas from the pig, where they isolated the beta cells and then perform what they call it as the xenograft, and then even the liver cells, currently with the induced pluripotent stem cell approaches, we do know that how we can actually cause the transdifferentiation or the set of transcription factors which you can actually exogenously provide to the liver cells to actually cause its differentiation to generate the beta cells or the pancreatic islet cells. And that could also be used for performing the transplantation, and then as well as even the pancreatic stem cells, which are also a small portion of cells present in the pancreas, from the same person you can actually isolate and then perform the allograft, or probably even the pancreatic precursors that are isolated from the adult from any patient. You can actually use it for performing the autograft also as well. The human islet or the beta cell transplantation, before it needs to be performed, say for example, when you're isolating the organ from the donor, the first step would actually be the trypsinization procedure or an enzyme based digestion of the cells invariably to segregate it. And when you perform this invariably using any of the enzymes, particularly like called as collagenase or even trypsin, which is a protease. Both of them are protease enzymes. And as you can observe in the figure that is shown over here, the doctors, as soon as they isolate the pancreas from the donor, they invariably perfuse it with collagenase enzyme. And by this approach, you can actually isolate these cells and then segregate the cells from them. And when you segregate these cells, these dispersed cell that is shown over here in phase 1 image, where you can observe it in the hemocytometer or the Newbar chamber, you can actually see the cells being counted. And once they are counted, then the required amount of cells are basically taken and seeded to generate the phase 2 image that is shown over here, which happens to be the aggregate of the beta cells alone, which are generated in the defined media. And this particular set of islet cells are further when visualized under the microscope at a higher magnification, you can observe how they are actually aggregated as shown in this particular image. As I already mentioned, the isolated beta cells, which could be useful for the graft transplantation process, there could be certain kind of pitfalls. What could be the pitfalls? It is like insufficient number of islet cells that you have isolated, or the poor quality of the islet cells that could lead to the failure to of them to actually engraft, or the toxicity of the immune suppressor drugs that you're basically using. And in case the how much ever you're trying to actually give the islet grafts to these people who require these beta cells for the insulin production, if the insulin is if they are actually said to be insulin resistant, invariably it will not solve the issue. This would cause the disease to actually reoccur once again, and then also in the case of allografts, also the occurrence of rejection is other kind of a feasible issues. So these things have to be actually properly monitored to understand about the islet graft failures. Stem cells, as I already mentioned, could be a positive solution for this treatment of diabetes, and I've also briefed about the grafting procedures in the earlier scenario. Uh, in continuation to that, stem cells, when you actually see that they are isolated, it could be induced pluripotent stem cells, it could be mesenchymal stem cells, or it could be hematopoietic stem cells. Any kind of stem cells, whatever it is, they if they have the potential to possibly commit themselves to the lineage of forming the pancreatic beta cells or the islet cells, you can actually try to differentiate them. And when you try to differentiate these cells, the beta cells that are basically formed from them, they have to be sorted and segregated, and you're going to choose, and then in the defined media only you're going to propagate only these beta cells. And when you're going to propagate these beta cells, as you know, the islet cells generally have the tendency to aggregate with one another, and this reaggregation to generate what you call it as the islet like structures, you can actually put it up into a patch kind of a thing, and then actually keep it in a transdermal way just below the skin. And this patch encapsulation when is actually could be very useful for people who are suffering from diabetes. And then if it is provided, invariably these stem cells which are actually present transdermally, whenever the cells require the adequate amount of insulin to be released, can be actually released from these beta cells. On completion of this transplantation of stem cell derived islet like structures to the recipient patients, we need to also look at these factors which are also critical to understanding about how the glucose management is actually observed in these patients. Islet like clusters that actually show the glucose stimulated insulin secretion are the ones that should be used for actually performing this. The earlier information which I provided, the encapsulation based transdermal patches, or probably even if not the clusters to be directly perfused into the hepatic portal vein system to actually reach the pancreas, or probably like restoring the patient's ability to produce and as well as release, thereby they can actually restore the patient's ability to produce and release insulin. Of course, it also obviates the need for monitoring the blood sugar levels and as well as the insulin injections that are provided to these patients. It eliminates the life threatening consequence of diabetes in them, and significant improvement of patients life expectancy and as well as quality of life can be actually achieved. How can you actually identify the cell that you have actually isolated from the pancreas has the ability to secrete the insulin? So here we look at a kind of a form of a progenitor cell or an early kind of a stem cell marker or a protein which is or a factor which is very importantly present in most of the pancreatic progenitor cells. The first specific progenitor cells for the pancreas are characterized by the expression of this particular parahox gene cluster transcription factor, which is called as PDX1. This particular factor, PDX1, is expressed particularly early in the case of embryonic developmental stage at 8.5 in the case of mouse, and its expression is required for the initial pancreatic anlage to bud from the endodermal epithelium. The second transcription factor, which could actually serve as a specific pancreatic progenitor cell marker, is called as neurogenin 3. And this is a helix loop helix containing transcription factor. This is also observed in the embryonic developmental day of around 9.5 in the case of mouse, which defines the first definitive endocrine cell precursor origin. Several of these transcription factors have now been delineated, which clearly helps you to understand which of these cells that you have isolated are actually having the endocrine lineage kind of a potential for it to actually secrete the insulin hormone. This illustration here shows how the human embryonic stem cells can be used for generating the insulin expressing cells in a two-step procedure. The first step wherein the blastocyst stage of the human embryonic stem cells are taken, and to which you are actually going to supplement them with certain kind of protein and as protein factors and as well as small molecules. They include nodal, activin A, fibroblast growth factor, retinoic acid, IDE1 and IDE2. When you supplement the human embryonic stem cells with these factors, this will enable in generating the definitive endodermal cells. And once again, in the second step procedure, where these endodermal cells are further supplemented with additional factors like endolactam 5, KGF, retinoic acid, and as well as cyclopamine, which results in converting or differentiating these endodermal cells to definitive beta cells, which are also called as the insulin expressing cells. There are exist certain challenges for also utilizing these embryonic stem cells as a source for generating the beta cells or the insulin expressing cells. One of the primary problems is that you can't be always sure that the endodermal cells from which you're using these factors for the conversion to generate these beta cells uh, can actually lead to the desired result of generating the beta cells. There could be a scenario where if there is an unregulated differentiation, the probability of an endodermal cells from which the generation of even GI tract cells or maybe even the respiratory tract cells or maybe the linear bladder cells can also happen instead of actually what you desire, which happens to be a insulin expressing cell. The second probable reason is that the element of doubt that is actually always there present with actually using these embryonic stem cell derived cells for generating these insulin expressing cells. The reason is that embryonic stem cells have the potential to also form tumorigenic cells, like which is called as the occurrence of cancer, which is called as the teratoma form of cancer, from the remaining undifferentiated cells which are basically present in the culture. And they when you have to be very careful when you are actually providing it as a transplantation option, and you have to be sure that actually before and after treat for the transplantation process, certain guidelines needs to be actually taken care to actually avoid the occurrence of teratoma formation. And the third scenario is that whatever cells that you actually try to differentiate from the embryonic stem cells, the final terminally differentiated cells or the mature cells doesn't mean that always you're going to get only the insulin expressing cells. There is a very good possibility that it could also be an non-insulin expressing cell. So certain kind of challenges do exist with regard to the usage of embryonic stem cells from which you want to derive the beta cells. In addition to usage of embryonic stem cells for generating the beta cells, the second probability of using the induced pluripotent stem cells for generating the beta cells is also of immense help. As you know, the usage of embryonic stem cells is generally banned in most of the countries, and very few countries actually allow it for the legal research purposes. Induced pluripotent stem cells are basically any kind of cells which are actually somatic cells which are actually isolated from a patient or from any person, can be used for generating the induced pluripotent stem cells. This conversion of the fibroblasts to the induced pluripotent stem cells is basically done by actually using one of the four transcription factors, which involves OCT4, SOX2, c-MYC and KLF4, which is actually placed in an adenoviral vector, and the transfection is performed to the fibroblast cells to generate the induced pluripotent stem cells. And once these induced pluripotent stem cells are generated, furthermore, they are supplemented with certain kind of key factors like activin A, epidermal growth factor, fibroblast growth factor, and the transcription factors OCT4 and KLF4. When they are supplemented, this results in the differentiation of the induced pluripotent stem cells to generate the mature form of beta cells or the insulin expressing cells. The third form of stem cells which could be used for generating the beta cells is called as the umbilical cord stem cells. umbilical cord stem cells, when they are actually subjected to the lentiviral based vectors, which includes OCT4, SOX2, NANOG, and LIN28, this results in generating the induced pluripotent stem cells, which we just now saw in the second method. And once these induced pluripotent stem cells are basically formed, just like what we spoke about in the second method, the same set of protein factors can be used for generating the insulin expressing cell. And in the second method of the umbilical cord stem cells, wherein first you're going to do the sorting procedure and then try to actually find that the cells which are actually positive for the cell surface marker CD133 and CD34, and when these cells are actually said to be called as the mesenchymal stromal cells, and to which you are actually going to supplement them with insulin, high glucose, and as well as activin A and retinoic acid along with fibroblast growth factor to generate the same insulin expressing cells. In other than the third approach, so you have the fourth kind of a stem cell based approach which can also be used, which is called as the hematopoietic stem cells from the bone marrow. And a certain part of the bone marrow is also said to contain what we call it as the mesenchymal stem cells presence. And these mesenchymal stem cells can be also converted directly to the insulin expressing cells, but currently the research is still going on. We are not sure what kind of protein factors are basically required. And in another case scenario wherein we do have certain kind of an information where by the usage of certain cytokines, you can actually convert the mesenchymal stem cells for actually generating the beta cells. We have seen how these stem cells can be actually useful for generating the beta cells. Stem cells that are isolated either from the embryonic or the umbilical cord fetal tissues or the adult cells basically can be expanded in vitro, and they can either be differentiated in vitro into glucose responsive insulin producing islet cells for the transplantation into the liver of the diabetic individuals, or probably the other approach is administer them directly into the circulation of diabetic patients, where they home in on the injured islets and as well as they differentiate to generate the insulin producing cells, thereby secrete insulin and thereby prevent the or regulate the levels of glucose. And the another approach is to administer something which is called as the stem cell stimulators, wherein we know already the drugs which can actually cause the stem cell to actually differentiate, or probably usage of certain things which is called as the growth factors specifically, or the hormones which can actually facilitate such an approach, can stimulate the endogenous stem cells to differentiate into the insulin producing cells. Emerging research is still suggesting that numerous approaches or ways to actually produce these insulin producing cells, thereby which can be useful for the transplantation in for the patients who are suffering from diabetes. And I hope so that in future it would lead to a probable kind of cure invariably for treating the diabetes in the case of patients, and then provide them with a permanent cure. I thank one and all for patiently listening.